for giving us.
Okay, we're
Thank you
live
for
here.
giving us a moment there to for the analysts to gather their thoughts. So we're going to continue with questions. This is docket number 22-32504-CON. It's the consolidation of critical care services by Sharon Hospital. So Mr. Clark, you can proceed with your questioning whenever you're ready.
Thank you.
Mr. Chuka, this is Ted Tucci. Would it be permissible, just based on the last series of questions, if I asked one question to help clarify?
Sure.
Thank you. So I'll direct this first to Dr. Marshall, but if any of the other witnesses care to comment. So you heard in the prior discussion some reference to and a use of the word termination. So just for the sake of clarity, I want to ask you, Dr. Marshall, if this CON application is approved, will there be any critical care medicine service at Sharon that Sharon Hospital does today that will not be available in the PCU unit on the second floor?
No, there will be no change in the level of critical care that we provide.
Okay. What will be different in terms of the physical space or location?
Just the location.
Okay. So when there's a reference to a termination, can you explain what the physical difference will be between what currently exists at Sharon Hospital and what is proposed?
Yes, the space that is designated as the unit currently, which is a mixed acuity unit now, will be relocated to a combined unit on the second floor. And that unit will cease to exist as it exists today.
So in that sense, the use of the space will be terminated, but the function will continue in a different location. Is that a fair summary?
Yes, it is.
Thank you.
Thank you. Mr. Clark?
Thank you. How will the proposal not adversely impact existing providers in terms of referral patterns, volume, staffing in the proposed service area?
So I can answer that question. We don't anticipate any changes in referral patterns or for any of the providers that practice at the hospital. All of that will continue as it is today.
In reference to page Bates, page 156, you provide a list of patients by service line who currently require transfer to other hospitals. Would this list be expanded if the proposal is approved? And if so, how?
So is the question, will there be any different or additional service lines as a result of the operation of the PCU? Is that the question?
Yes. I refer to you. I refer you to page 156.
Yes. Yes, we don't anticipate any additional service line being transferred out of our facility, and we don't anticipate much change in the numbers of patients that are having to leave the facility. As you see, it does fluctuate on a year-to-year basis, but again, we're going to continue providing the critical care services that we provide today. All of the doctors are going to stay the same. All of the nursing staff and support staff are going to stay the same. It's just a new location. And so we don't anticipate an impact to any of the transfers.
You also mentioned, will the proposed improvements in tech capabilities be made even if the application is denied? What if the application is denied? Will the proposed tech capabilities or enhancement will they still be established?
Well, I guess this is Dr. Murphy. I'll take a stab at it, perhaps. To the extent the application is denied, my view is that this would prohibit us or complicate our ability to provide care in a more efficient manner. And that is really the thrust of much of this application and our overall plan, is to continue to deliver appropriate high quality care to the community, but to do so in a way that's cost efficient. So in that respect, denial of the application would be a challenge.
So just to clarify, I think in the first session of the hearing, it was discussed, certain things were discussed as being like new technological capabilities that were going to be brought into the PCU setting on the second floor in terms of, video monitoring and additional heart monitors and things of that nature. I think the question was just, will that plan change even if the proposal is denied? Or like, do you anticipate moving forward with the acquisition of that new the new technology, even if this is denied, or is it contingent upon it being approved?
Right. So much of the equipment that we discussed last week is already in place on the medical surgical unit, which will be the new location for the proposed PCU. So the cardiac monitors, the remote telemetry monitoring were installed on that medical surgical unit last year. And that was installed on medical surgical unit because that is really the standard of care for medical surgical units. So we're able to monitor the patient's their cardiac status on the medical surgical unit. So those are already in place. Those were purchased in 2022. The video monitoring for the virtual sitting that we talked about, that's already in place. We use that across the hospital in a couple of different units. So that's not anything new. What we did talk about that would potentially be new in the new unit is something that we currently have in the ICU. And those are the wall mounted cardiac monitors. If we do move to have the PCU upstairs, we would provide those in a couple of the rooms. We do currently have those in the ICU today. But I want to just talk about the current ICU as it stands today. Our ICU, the isolated unit that it's in, is extremely outdated. We have a 9-bed unit, and we have equipment that needs updating. We have an entire unit that really needs updating at a high cost. And so, we need to consider what we're going to do should this application get denied. We have an underutilized unit on the second floor. And so that's why we are proposing to take all of our patients and be able to care for them in that underutilized unit so we can best utilize our space. If we have to invest money into the current ICU space, the story stays the same. We still have underutilized units, and we're not creating any more efficiencies or really being able to move forward in the care we provide. And we're not going to be able to reutilize that space for something that, other parts of our plan, how we're transforming the hospital, want to grow different areas. This is really a critical piece of us moving forward as a hospital.
And I just want to add that up until recently, the only place in the hospital that patients could be on a cardiac monitor was in that unit. But we've now brought in telemetry monitoring, cardiac monitoring to the med-surg unit on the second floor, thereby reducing the need for cardiac monitoring in that unit. And where it's appropriate for patients to be on a monitor on a med-surg unit, that's where they're going to be. They're not going to be downstairs.
So Dr. Marshall.
I'm sorry, I just wanted to ask one additional follow-up. Ms. McCullough, I think you referenced the Vassar the Vassar units on the nurses' wrists. Are those already implemented as well?
Yes.
Okay. Thank you. Sorry, Mr. Clark, you can keep going.
Thank you. So, Dr. Marshall, on pages 109 to 115 of the main application, Sharon 105 to 115, the article you provided talks about the difference in ICU to PCU as being one relating to technological capabilities. Would the proposed PCU have the same tech capabilities as its ICU?
So
Can you just give us a minute? I want
Sure.
to get you to the
okay,
article.
okay, sure.
So I'm handing the witness the article that begins at SH 00109. Just take a minute to look at that.
Sure. Nursing, I think I've seen this.
So if you just want to comment briefly on that article, and then I think Mr. Clark's question was, can you talk about the technology capabilities in the current space on the first floor and compare it with what will be available in the mixed acuity PCU on the second floor?
Sure, sure. So, so the article references some of the similarities between the care provided on a critical care level in progressive care units of various level and intensive care units. So the technology that exists now in our unit that we call the intensive care unit is outdated. And so the technology that we'll be bringing once this CON is approved will be of better quality, and there will be an enhancement of those monitoring capabilities. So the short answer is that there will be no decrease in the level of critical care and technology, only an improvement.
Thank you. Does Sharon have a long range service plan? If so, what does it involve?
Dr. Murphy?
Yeah, we do have a transformation plan. This is a part of it. A number of applications are actually part of that transformation plan. And what we're trying to do is offer the quality of care that we can appropriately offer in the community and supplement it with what we call wraparound services, ambulatory services, primary care, geriatric services, additional geriatric psychiatric services, and there are a number of other programs we would like to bring into the community, including access through telemedicine to additional specialists, all of which really was something that we worked on for the last couple of years, actually, so that we stopped chasing these losses and we somehow turn the hospital around so that it has a future. We do think that our plan offers a viable, successful future for Sharon Hospital so that it's going to be here 25 years from now. And you know, we've tried very hard to get some very smart people to help us with that plan. We've had the hospital board endorse it. We've had medical staff leaders look at it. We've shared it and had the community help us create it. And we would be happy. I'm sure you have that that plan. But we've given this a great deal of thought. And actually, the plan was endorsed by the Sharon Hospital Board as well as the system board 18 months ago.
Dr. Murphy, given the geographic location of Sharon Hospital and its size and capabilities, can you just explain in a little bit more detail why the services that you want to offer going forward are the ones that make sense for the community that Sharon Hospital serves?
Yeah, I think that, you know, this begins with an understanding of what does the community need. And, you know, we have done the community health needs assessments, and we are trying to responsibly position a range of services that meet the primary and most pressing needs of that community. And it has to be a balance, we think, of inpatient and outpatient services, as well as emergency services, but increasingly ambulatory services anchored by primary care. And that's really what our plan has contemplated. And it has to be fashioned in a way that is financially sustainable. The present set of circumstances, as you've heard many times, is unsustainable. And I think if we don't quickly address those issues and these enormous inefficiencies, the viability of the hospital is at stake.
Can you just explain how re-engineering the suite of services that Sharon Hospital is able to offer to the community will help bring financial stability to the hospital?
Well, we started really by looking at what are the particularly inefficient services that we're offering. And, you know, we're not the first set of individuals to look at this. Perhaps I can share with you my perspective on other rural hospitals in America. Rural hospitals, as I'm sure you know, Mr. Clark, have been under enormous pressure for a long period of time across this great country. And going back to 2012, Congress was sufficiently concerned by the availability of care in rural communities that the House Ways and Means Committee asked MedPAC to prepare a study and analyze and make a series of recommendations as to how best to preserve access to healthcare in rural communities. It brought forth that report. MedPAC, by the way, is a nonpartisan, independent agency of the legislative branch of the federal government. And on MedPAC sit 17 of the nation's leading healthcare experts, and they are supported by 22 policy analysts, bright individuals like yourself, and supported by research assistants. So they studied the issue. The problem, however, didn't go away. And in 2020, actually, a rural hospital in the United States closed every 3 weeks. Congress again got concerned and asked MedPAC to go back and refresh the analysis. And the analysis, by the way, is 403 pages. It is available on MedPAC's website. And it was published June 15th, actually, in 2021. And it fundamentally offered 3 core principles as part of their recommendations. And this gets back to Attorney Tucci's question. The first principle that it brought forth, having studied the issue for more than a decade, is equivalent access to care does not mean equal travel time to those services, particularly specialized services that require a higher volume of patients to sustain in a financially viable way those programs and services. The second principle that the report offered was that with respect to the quality of care that rural hospitals offer, when you're offering non-emergency services, there should be equivalent quality in rural settings and urban settings, meaning if you choose to offer a healthcare service in a rural setting, it had better be as high quality as it is in an urban setting for non-emergency care. For emergency healthcare services, MedPAC acknowledged that there are different standards that should be applied because there is lower volume, fewer staff, and less technology. Our proposal recognizes both of those principles in that we're saying when care requires a sufficiently high and sophisticated level of intervention, those people need to travel or would be transferred to a tertiary care facility that is appropriately staffed and designed to accommodate them. But the more routine critically ill patients, if you will, who can be cared for in Sharon, will be cared for in Sharon. But the third recommendation in MedPAC's report, I think, is essential to the integrity of our application here. What MedPAC reviewed were 4 different methods of payment to rural hospitals. And it said, it acknowledged rural hospitals need additional incremental financial support. So how best should we do that? And what it concluded emphatically was you can't just provide 100% or maybe 105% of costs and say, whatever it costs you to deliver that care, we're going to give 5% more, because that didn't work. It hasn't worked. What they said was the payments should be targeted. They should be empirically justified, and they should be designed to encourage efficient delivery of care, which is exactly what we are trying to do, to deliver the same care in a cost-efficient, a more cost-efficient manner. The report went on to look at 40 rural hospital closures in the United States between 2015 and 2019. And there are several conclusions that the committee drew attention to that I think are relevant here. The first is, in all of these cases, prior to the closure of the hospital, this is all across the United States, inpatient admissions slowly but inexorably declined. There wasn't a conspiracy to send patients out of the community. It wasn't get rid of nurses so you can't care for these patients. This happened everywhere because local residents decided to seek care at those tertiary centers further from home. We didn't invent this problem. We are trying to confront it responsibly. Another observation was newly trained physicians don't really often want to come to rural communities to set up shop. It's too difficult. This was seen all across America. The third conclusion the report found in looking at 40 hospital closures was that even hospitals that belong to big systems, regional systems, it didn't matter. Once the financial subsidies became too great to justify, rural hospitals that belong to healthcare systems closed. And that, I'm afraid, is what I'm worried about. The MedPAC then went on and made another recommendation. And we're not there yet, and I hope we don't get there. But it advised Congress, and Congress acknowledged, received, and acted upon this recommendation in the Consolidated Appropriations Act of 2021. It came up with a new hospital designation for rural hospitals called rural emergency hospitals. Now that came into law, and you may have seen this, reports in the New York Times, the Washington Post in January of this year. Those payments are now available to rural hospitals in America if you meet the criteria, rural emergency hospitals. And what the payment is it's predictable, it's monthly, it's enhanced for both inpatient care as well as a 5% bump in outpatient care. But it comes with a catch. And the catch for this designation is you are prohibited from providing inpatient care. So you have to close the inpatient units. So I think that the federal government is basically tipping its hand, saying, if you want to stem these losses, close the inpatient unit. What we are trying feverishly to do is to avoid that fate, to provide inpatient services, to continue to keep those people employed, to provide outpatient services, but to do it responsibly and cost efficiently. That is the very basis of this plan. It has been shaped by experts, refined by medical staff, endorsed by the board, and broadly communicated to the community. We've had 30 meetings over the last 16 months, community meetings. I think this is a highly responsible plan. This application conforms to all of MedPAC's recommendations. Now, you've heard from our critics who represent, in my view, a small view of the community. The majority of the community thinks and thanks us for taking this on and avoiding what I think could be around the corner, which is we can't keep losing $20 or $25 million a year. So we are trying to reshape the services in a responsible way to best meet the needs of community. That doesn't mean being all things to all people. Our critics, I think, have a distorted view of the past, and they are reluctant to look ahead at the future. this is the future of Sharon Hospital. I think a failure to endorse the plan represents an injustice to the community and ultimately threatens the viability of the hospital. So that's perhaps a long answer to the question, but I think that's at the heart of what we're trying to do here.
Well, I just want to ask a couple of questions to address some of the comments you made so that it's clear on the record. Under the transformation plan, as you've described it, is
I
one
want
of
to
the go-
object, I want to object at this point. This is supposed to be a period when the staff is asking questions. I haven't objected to Mr. Tucci asking a few questions, but I would think that we would want to get the staff questions answered. The weather here is, snow is coming in, and it seems like we're moving back toward presenting further testimony as opposed to answering the staff's questions.
I was planning to allow Attorney Tucci to do some follow-up on the OHS questions anyway, and I've determined that this is probably the most efficient way of dealing with that. A lot of the information, or a lot of the questions he's asking and the information that's being elicited is responsive to the questions that OHS has asked, or follow-up questions that OHS would be, I imagine, interested in asking. So I'm going to allow it, and also I'm the intervener isn't allowed to make evidentiary objections to the best of my recollection, so I'm going to overrule it for that reason as well.
Thank you, Mr. Chuka. I just have two brief questions of you, Dr. Murphy. Can you tell Mr. Chuka and OHS staff, is part of the transformation plan in terms of its goals the ability to preserve Sharon Hospital's capacity to continue to have inpatient care at the hospital?
Absolutely.
It's not your goal to end inpatient care.
No, I want very much to preserve it.
And what about with respect to the emergency department? Under the transformation plan, will Sharon Hospital continue to operate and offer services to community members of an emergency department that operates on a 24/7 basis?
Yes, I think that is actually at the top of the priority list.
If a patient who lives in the service area has a life-threatening emergency, will they be able to come to Sharon Hospital under the transformation plan to get care at the emergency department on a 24/7 basis?
Absolutely.
Do you want them to keep coming to Sharon Hospital to get that care?
Very much so.
Thank you.
Dr. Murphy, was the MedPAC report provided in connection with this proceeding, if you're aware?
I don't think so, but it's on medpac.gov, June 2015. And I made reference to the contents largely that contained in chapter 5.
So, I mean, we aren't really allowed to look outside of the record, so I'm just
Oh,
going to
we'll
ask.
provide it as
Okay.
Provided
we'll provide it.
as an exhibit.
It's 403 pages, so just get a printer handy.
I apologize for talking over you. We will provide it.
Okay, thank you. And I did have one other question based on something you said earlier, Dr. Murphy. You said there are quote, a number of applications that relate to the transformation plan. Are you referring to CON applications?
Yes, Mr. Chuka.
So I'm aware of only this one and the one concerning maternity, the termination of maternity services. Is there something
Right.
else?
No, that's what we're talking about.
Okay. Thank you.
This is Steve Lazarus. Just one question as a follow-up, Dr. Murphy. You have referred to Sharon Hospital as a rural hospital, which we get geographically it is. Would it also be described as a rural hospital under CMS definition, federal definition?
Yeah, it is. I believe its current designation is a sole community hospital designation, which is a type of rural hospital.
And that's contained within the definition of a rural hospital?
Yes.
All right, thank you. That was my only question.
You're welcome.
Armand, you can go back.
Thank you. It refers to base page number 34. There you claim that access won't be reduced. Even if that is true, the statute requires a showing of improvement in access. How will this proposal improve access to healthcare?
Well, I'll take a stab at it. I think if the question is, how will this proposal improve access to healthcare?
Yes,
Well,
sir.
I think just specifically, we're focusing on access to critical care services. So can you talk specifically how you believe the establishment of the mixed acuity PC unit will improve availability and access to critical care services?
I can answer this question. Today, we often have challenges in staffing our current ICU. There's a nursing shortage, and I don't think that's unique to Sharon Hospital, but we certainly feel this shortage in our intensive care unit. There are periods of time where we have to limit the number of patients that we can care for, and that's related to having enough nurses available to care for those patients. We do anticipate that this change will allow us to be able to staff more efficiently by having all of these services located on a centralized unit. I'll just explain again kind of what we're looking at. We have a unit on the second floor of our hospital. It's called 2 North. It's a medical surgical unit. It has 28 beds with an average daily census of 10 patients. So it has the capacity to care for, on average, 18 additional patients on any given day. Our ICU, which is on the first floor, is a 9-bed unit with an average census of 4 patients. And so you'll see that if we take those 4, in addition to the 10 that we have on the second floor today, that gives us an average census of around 14, again, in a 28-bed unit. So this will allow us to take all of the staff that we have and be able to care for all of our patients in one centralized location. And there's a couple of benefits from that. One is when you're dealing with low volumes and a low number of patients, we don't have a lot of staff to care for those patients. So if we have 2 staff upstairs and 2 staff downstairs, now in this new consolidated unit, you may have 4 staff members to care for the patients. So it's more resources, it's more hands. And with our plan to educate our nurses on the medical surgical unit and have them competent to care for critical care patients, we now have more nurses that are going to be able to care for patients that need critical care services. So that will increase our capacity to be able to care for those patients, limit some of those caps that we have to put on being able to care for those patients that we experience today.
Thank you. How will the proposal impact staffing at the hospital, considering it states nothing will change? The hospital in general.
I didn't hear the question. Did you?
I didn't catch it.
How
How
will
will
it be?
staffing change with the proposal?
How
changes?
will the proposal impact staffing at Sharon, considering it states nothing will change?
Yeah, so some of what I just described is how that will be impacted by having the same staff in one consolidated unit. It will give us more capacity. Am I answering your question, Mr. Clark?
Yes.
Okay.
Thank you.
I think that the benefit of having them in one unit is that, you know, it's not only the nursing care, but the ancillary care, you know, the people who clean, people who support the staff in other ways, the unit coordinators, they're all in one unit so that the the efficiencies can be realized. And I think that that's really how this improvement will play out.
So this will not affect ancillary staffing?
This will only improve ancillary staffing.
Okay. Thank you. Can you provide a side-by-side comparison of what acuity cases the ICU is currently able to handle versus what it will be able to handle as a PCU?
Sure,
Yep,
I can.
We can put something together.
Would you like a verbal response or?
As a lay
Go ahead.
faculty,
Yep. Sure.
Oh, okay.
So currently our unit can take care of patients who have any number of illnesses such as pneumonia, heart attacks, congestive heart failure, infections, sepsis. The list goes on. The new located unit will take care of those same patients. So when we talk about specific issues, I'll give you some examples. So one example is a patient with a severe infection. So a severe infection can cause a syndrome that we call sepsis, where the infection results in tissue damage or organ damage, sometimes low blood pressure, and sometimes those patients require medications to support their blood pressure. That type of patient is stabilized and cared for in our ICU today, and that same patient would be stabilized and cared for in our PCU tomorrow. Now, that same patient, if they do not respond to therapy and become unstable or require additional therapeutics that we don't typically provide, those patients would be transferred just like they have been in the past. So all of those patients, the heart attacks, the strokes, the congestive heart failure, the pneumonia, all of those patients that are currently cared for today will be cared for tomorrow in the PCU.
Can I ask one follow-up question, Mr. Clark?
That's fine with me. So
Thank you. Dr. Marshall, can you tell Mr. Clark, in terms of the side-by-side comparison he's looking for, has there been an effort that you've been involved with to examine and refine the initial draft of the policy that was created around the operation of the PCU?
Yes, absolutely.
And have you been working on that?
Yes.
Is there a more recent draft that has been prepared and or is in the process of being worked on?
Yes.
We will offer that to OHS as a late file.
thank you.
Thank you. Are you able to, are you aware of any studies that have been performed on what happens to hospitals after they have transitioned from ICU to PCU, either at the hospital level or at the service level? And do staff members leave? Do the hospitals maintain surgical volume, ED volume, other hospital volumes?
Well, I don't know, I can't cite for you a published study. I can share with you personal experience in another hospital in this state of which I'm the CEO, where we did the very same thing. It, I think, very much satisfied the community and preserved the opportunity to have inpatient beds. And that was at the Milford Hospital. So I think it's feasible. We've done it successfully, but in terms of an academic or peer-reviewed publication, I can't bring one to mind.
No, I can tell you that there was an article, and I can't cite it exactly, but I could probably find it, but it talked about the changes in acuity that have been seen in progressive care units over the past several years, particularly since COVID. And so I think, as I mentioned earlier, when COVID was at its peak in the early days of the pandemic, our ICUs nationally became filled and overfilled. And the care of those patients that were slightly less acute fell to the progressive care units. And as those progressive care units developed and were able to care for those patients, it became more of a standard that level of care was appropriate for a PCU. And down the line, you can see that the care provided on some med-surg units has risen in response to this change in acuity over time.
I think the other thing I might offer, Mr. Clark, is that one of the reasons we reached out to a firm that specializes in rural healthcare is to say, hey, look, we haven't seen hundreds of hospitals. And as I may have shared with you previously, I went to the leadership at the American Hospital Association and asked who they recommended as the nation's leading expert on the provision of services in rural hospitals in the United States. And that's how I got Stroudwater's name. When they came and did their assessment and met with a variety of individuals, including doctors, community leaders, and board members, I believe their first recommendation was that we needed to do this. What it is we are proposing today is that you have to have this progressive care unit as the first step in trying to preserve care, but delivering it in a more cost-efficient manner. So they were very quick to recommend this. And I would say that the inference I drew was that this is in fact done regularly to preserve this level of care appropriately in rural settings.
Dr. Marshall, the article that you referenced a little while ago, just in terms of, the change in PCU post-COVID from pre-COVID, that's along the lines of the type of article I asked if you were able to provide after the fact. So thank you for referencing that. If you're able to find that, I would appreciate it.
Will do.
Thank you. If this proposal is approved, or the other proposal you have pending under docket number 22-32511 CON is not, will you still move forward with this proposal? And similarly, if the other proposal is approved, but this one is not, will you still move forward with the other one? Why and why not?
Yeah, I would say, Mr. Clark, I'll try to take a stab at it because perhaps I'm closest to the governing body. I firmly believe, deeply believe that we have done our very best thinking and provided a comprehensive plan that represents a whole lot of thinking, creativity, input, and really contemporary views on how to preserve access to care in rural communities. We have been forced to compartmentalize that plan and divvy it up by virtue of state statutes and this process, and we've respected it. As I mentioned last time, I think it puts you in a little bit of an unfair position, perhaps, in that we're giving you a stool that has one leg and asking, can you sit on it? I think the right way is to give you a stool that has all three legs and ask, can you sit on it? We need all three legs. I cannot imagine that the board is going to allow me to continue to lose enormous sums of money and not basically do what other, as I mentioned a moment ago, rural hospitals belonging to larger systems have done and say, call it a day. This model cannot continue. I can't presuppose it. I have never discussed it with the board specifically, so I don't have a direct answer, but I've been in front of them long enough, including yesterday for 2.5 hours, to know that the rate of loss is of enormous concern, and that a fractured approach that represents part of this plan is unlikely to be viewed in a positive light.
Thank you. Let's refer to base page 29 to 30 and 30.
We're there.
There you stated the proposal will have no impact on quality. However, the statute requires a showing of improvement in quality. So how will this proposal improve the quality of healthcare delivery?
So I can take that. Sharon Hospital is a hospital that delivers high quality care. We are a 5-star hospital as recognized by CMS for multiple years in a row. And we continue to monitor all of the patient outcomes and quality metrics to ensure that that high quality care continues. We anticipate that that will stay the same with this newly proposed PCU. We will continue to provide high quality care. We'll continue to monitor all of those patient outcomes and quality metrics to ensure that that occurs.
Thank you. Dr. Murphy,
Yes, sir.
can you explain how this termination of services can be implemented without negatively impacting patient safety and the quality of care for patients?
Well, once again, I hope you don't find this to be argumentative, but I do feel that termination is a misnomer. I really do. We're going to continue to provide the same high quality care that is appropriate in the opinion of the clinical staff that's taking care of these patients. We're going to do it on a different floor in a more efficient manner. There are going to be more eyes on the floor, and I think actually that safety will be enhanced because, as you know, the more people that are around, sometimes you hear something or see something as opposed to having 2 nurses on a unit, one of whom needs to use the restroom, and all of a sudden 50% of your staff is off the floor. I do believe that co-locating these patients in a mixed acuity unit with appropriate and updated technology is a step towards improving the safety of the care that we're delivering.
Thank you.
This may be somewhere in some of the documents that you've submitted, but is there a minimum volume of patients necessary to be able to provide critical care services safely at the hospital?
No, that's nothing that we've seen in any research that we've done.
Okay.
But one of the benefits of this type of unit is that it's flexible and it's mixed acuity so that we can flex up or flex down.
Okay. Thank you.
Thank you. I have a few questions which are unrelated to the application itself.
Sure.
Dr. Curry stated that there recently have been patients waiting in the ED for an ICU. Is this true? Are there wait lists? How long are the wait lists?
I can talk about that.
Okay.
So there are times when bed availability is reduced either due to census or to staffing. And in the case of a patient who is in our emergency department that requires a monitored bed, they may, if the bed is not available, they may have to remain in the emergency department until that bed becomes available. Lately, the main reason for this has been staffing, nurse staffing. With our proposed progressive care unit, I believe we'll see less of that because of the efficiency of having all the nurses and all the ancillary staff on one unit.
Dr. Marshall, can you just explain in a little bit more detail when you talk about bed availability as it relates to the capacity of nurses to provide care? It's not that in the ICU you don't have enough beds. Is that correct?
Correct.
You
correct,
have the capacity to physically house 9 patients, correct?
correct.
What you may not have, and what you experienced in December and January of this year, is the inability to provide care to patients who might be in those beds because you didn't have the nurses.
Correct. Correct. Without adequate nurse staffing, it would not be safe to put additional patients into that unit.
So that's how many nurses are currently assigned to the physical space called the ICU?
Is it 2 most of the
2
time?
per shift.
Yeah.
Yes.
So if somebody gets sick or if there's an emergency and you only have 1 nurse,
Yes.
you can't bring some other nurse in from a different part of the hospital to do that service. Is that correct?
No, that's correct. We have limited trained critical care nurses.
Yes.
And how would there be a benefit if you were able to aggregate or create a single nursing team on 2 North in a PCU mixed acuity unit? How would that help alleviate the problem?
So in this proposed model, all of the nurses that we currently have in our ICU and all of the nurses that we currently have in our medical surgical unit will all be trained to care for critical care patients. So it will increase our ability to care for critical care patients just by having more nurses trained to provide that level of care.
So once all of that training is completed and you have more nurses who are competent to provide critical care, does that mean if there's increased patient demand, you have the ability to staff up the number of nurses to safely care for those patients?
We should, yes.
Thank you. On page 2 of Dr. Kirsch's pre-file,
We're gonna need a minute.
Sure.
Just 1 second.
Okay, we have it.
We're good.
Dr. Curry stated that there are 9 ICU beds. However, is being used for storage. When calculating utilization, does Sharon Hospital use 8 or 9 as their denominator?
So our current ICU has 9 physical beds, all that can be used for patient care if we needed them. Our average daily census, the number of patients that we have in any given day, is an average of 4. And so it is rare that we need 9 beds. We do have 9 beds, all with the same equipment. Access to oxygen and medical gases are in all 9 beds. There is one room that Dr. Kirsch is referring to that the nurses will place IV poles or chairs or equipment that's not being used in there, all which can be removed in the case that a patient is needed to go in that room.
So
Thank you.
just to clarify, though, that the data and the information you have provided, does that assume 9 beds or does that assume 8 beds?
9 beds.
Okay.
9 beds.
So Ms. McConnell, still on page 2, Dr. Curry stated that the ICU has closed from time to time. In particular, he stated it closed for 6 days from February 9 to 15/20 in 2022. When calculating volume, does Sharon Hospital use 365 days as its denominator, or the days that the ICU is open?
Do you mean in terms of calculating the average daily census? What's the denominator?
Yes.
So I believe we do use 365 days, but I'd like to clarify the statement that we are closed from time to time. There was one period of time, and I believe we submitted this with some of the completeness questions. I don't remember the exact dates, but there were a couple of days that we weren't admitting patients. This was solely due to not having any ICU nurses to take care of patients for those particular days. And so we weren't admitting ICU patients during that brief period of time. But that is the only time that the unit was not admitting ICU level of care patients.
Right. And that's not to say that there haven't been times where we have not had any ICU patients and had adequate nursing, but just
Right.
not the patients.
And an example is just this past week, we just had a stretch of 3 or
Two
So-
plus days.
days where we had 0 patients admitted to the ICU. We had nursing staff. That was just, there weren't the patients that needed to be admitted to that unit for that level of care. So that also contributes to the average daily census.
Does that mean that on those 2 days, you had nursing staff in the hospital, correct?
Mhm.
Prepared to deliver care to patients who needed critical care services, correct?
Yes,
And there were no patients,
Correct.
and they were here, and you
Correct.
paid them.
Yes.
Yes.
And on the following page of Dr. Curry's pre-file, he stated that the hospital adopted a policy of giving, oh, let me give you some time.
Yep, we're just grabbing that. Okay, we have it.
Dr. Curry stated that the hospital adopted a policy of giving preferential admission to patients with lower acuity conditions over patients with higher acuity, traditionally ICU level patients. Is this true?
So, Mr. Clark, just for the record, this is part of what we are going to be moving to strike. I won't comment any further on it because I don't think it deserves to be dignified with comment, but I'm going to allow the witnesses to answer.
Yeah, so this is not true. We never followed a new policy. Our admission criteria has not changed for the ICU. There is a work group, and we've talked about this earlier today, that has been working on a new PCU admission policy that would be used in this new proposed unit should it get approved. And that's been a work in progress. There's different drafts as we get feedback from the clinicians that care for our patients, but that policy was never approved or put into use.
Thank you. On page 6, Dr. Curry stated that, oh, let me.
Okay, we have the page.
Dr. Curry stated that nurses have told him they will leave if the proposal is granted. Have any of you or any other executive of your hospital received similar information?
Just note again, this will be part of the motion we submit to OHS. You may answer the question.
So our nurses have been involved in this planning. Their feedback is very important to us, and we've made many changes to the policy and to taken their suggestions on equipment, an example of that being the bedside monitors, and are adapting what we're doing based on the feedback of our clinicians, because that's most important, that they're going to be able to work in this new environment. it has not been communicated to me that nurses are intending to leave due to this change. I've had conversations with many of the nurses, and that has not been a part of that conversation.
And it has never been communicated to me either.
Nor me.
Thank you. Page 6 to 7, 6 and 7.
We're good?
Dr. Curry stated that if granted, the proposed setup would be insufficient for proper PCU monitoring. Are the rooms to be used built to provide critical care safely?
Yes, they are. And I know we talked a little bit about this last week, but I can refresh your memory on that. So we have a 28-bed unit on the second floor. And the way that the mixed acuity PCU will be designed is that any of the 28 beds can be utilized for any patient requiring either medical, surgical, or PCU level of care. We are able to do that through all the rooms have oxygen capability and suction capability. We have portable telemetry monitors that can be used in any of the 28 rooms so that we can monitor a patient's cardiac status. There are select rooms on that unit that have additional capabilities. There are 6 of them that have specific medical gases so that if a patient required respiratory support through a ventilator, we would be able to do that in these 6 specific rooms. So that is really the only difference between those rooms and the other rooms. We also talked last week about the visibility of the patients because that is something that Dr. Kurish brought up as a concern. But we have many rooms on the second floor that are visible from the central nurses station. We also have additional monitoring capabilities. Those being, we have we have many portable workstations that our clinical staff can use to do their work, their documentation, or other duties by using a portable workstation that can be moved to anywhere on the unit, including inside of patient rooms. We also have in all of the patient rooms windows installed on the doors so that if a door is shut, a patient can be visualized from the hallway. And we also have video monitoring capability so that we can utilize a camera on wheels that is used to monitor a patient with a technician watching the patient through the camera that's located in a central room to watch that patient either for fall precautions or other safety reasons that we'd like to have a closer visual on the patient. So we have many mechanisms to be able to ensure that we're providing critical care services safely.
The other piece I would offer a perspective on with respect to your question, Mr. Clark, is what Dr. Kurish's letter doesn't contemplate is the preservation of the status quo. I continue to believe and worry that all inpatient care might go away. This is a highly desirable alternative to keeping patients in an understaffed, outdated unit. This makes sense. This preserves care in the community. This preserves jobs. And his letter clings to an outdated model that we cannot sustain.
Okay. Is there anything that needs to be done prior to the establishment of the PCU on the second floor?
Meaning
Any additional work?
Logistically, also?
No, the physical unit will stay the same. The only additional thing that we would like to do, and this came from our work group and feedback from our clinical staff over the last few months, is there's a request for bedside wall-mounted cardiac monitors in addition to the portable cardiac monitors that we have. And so we would like to install those for certain PCU patients that may require a closer monitoring. But other than that, there are no changes to the physical layout of the unit.
Okay. Does the hospital have any plans to invest capital into the proposed floor?
So the only capital investment, again, would be for those wall-mounted cardiac monitors that came up over the last couple of months. But the unit on the second floor is a much more updated unit than the current ICU. It is not in need of any major remodeling. You know, there'll be additional workstations, like a computer workstation for a doctor or a nurse, because there will be more staff up there. These are not high dollar items. These are things that we do every day in the hospital and are just considered part of the normal operating budget.
Thank you. So we have a few, thank you so much. We have a few questions for Dr. Koresh.
Before we get into those, let's just take a 5-minute break.
Okay.
So we'll come back at 3:16. Actually, let's say 3:17.
It is.
That's right.
We're not recording yet. We have to wait for the applicant. So we are picking up from where we left off in docket number 22-32504-CON regarding Sharon Hospital's proposed consolidation of critical care services from the ICU into the PCU. Mr. Clark, do you have any additional questions for the applicant?
Yes, yes, I do.
For the applicant?
Actually, for Dr. No. I've concluded
Okay.
my question to the applicants.
Okay. Attorney Tucci, do you have any additional follow-up based on OHS's questions that you wanted to address?
No, thank you very much. I appreciate that.
So as Mr. Clark just mentioned, it sounds like he does have some questions for Dr. Koresh. So Ormond, you can proceed with those whenever you're ready.
Thank you.
Actually, let me just verify. Dr. Koresh, are you available to speak and ready to go?
Yes.
Okay, thank you.
Dr. Koresh, on page 2 of your profile,
And Attorney Tucci, I know that this is also probably going to be the subject of your motion, but I'm just going to allow it for now. And then we'll address it once we get to that.
Thank you. I won't interject in the questioning.
are you ready, Dr. Koresh?
Yes.
Thank you. You stated that you believe ambulance attendants know which patients are apt to be transferred from Sharon Hospital and will attempt to take many of these patients to other hospitals to avoid future transfer. What is this based on? Can you provide specifics?
From my patient experience, I've had patients over the last couple of years that summon an ambulance for various reasons, painting, whatever, belly pain. And it's the ambulance attendants want to take them to Vassar if they're in New York State. Patients want to come here, and if they insist, they are brought here. If not, they go to Vassar, which is twice the distance. This happened to me this last year with a person who fell in a house because she was weak, and another patient with abdominal pain. And so the ambulance attendants make a decision what they think is going to level of care the patient is going to need. And if they think it might need a higher level of care, they make that decision.
Thank you.
Sorry, Dr. Kirsch, how many times would you say that has happened over the past 5 years, or that you've been notified about that?
3 or 4 times in the last year.
Did it happen prior to?
No, years ago, it never happened. Never happened. See,
Okay.
3 years ago, it never happened.
Okay.
On page 4, Dr. Koresh.
Go ahead.
You stated you believe that if the proposal is granted, surgical volume and ED volume will decrease. What basis do you have for saying this? Can you provide any scholarly articles to support the conclusion?
I can't give you any scholarly arguments, but I just know, for instance, now we have 1 surgeon instead of 2 surgeons, and oftentimes there's not surgical coverage for the emergency room. And those patients, when there's not surgical coverage, are taken elsewhere or sent elsewhere when they're brought to our hospital. That's been a problem since last May, when we used to have 2 surgeons. Now we only have 1. So more patients are transferred for surgical regions now than used to be transferred.
So how does that relate specifically to this proposal?
Well, I think the same thing would apply to medical patients, that if we're not going to have an adequate number of nurses and critical care beds, that those patients will end up being transferred.
Okay.
Thank you. Thank you, Dr. Koresh.
Do you have any questions for Dr. Jermack, Mr. Jermack?
No, I don't.
Mr. Hearing Officer?
Yep.
There were certain questions that were asked of the hospital as to which I'd like Dr. Koresh to be able to respond. They've changed their goalposts from what they testified earlier, in our opinion, and certainly from what they put in their application. In their completeness questions, they said there'd be, and their application, they said 10% fewer patients, and then they said the 24 per year fewer patients, and they didn't change that during the session last week. They said that there were going to be changes in the admissions policy, but they only mentioned, the only changes they mentioned related to intubation and not to other things. Now they're saying they're going to take everybody they take now. And so I think it's important to the process. All this should have been put out before the hearing last week. And at the very least, we need to give Dr. Koresh a chance to respond to the points that they've made. So I'd like to ask whether I may just bring that out in response to what has been stated on by the hospital.
Mr. Tsuka, if I may be heard.
Sure.
So I object to that. That's highly out of order. It will impair the orderly process of the hearing. Quite frankly, this is not a debating society. We're not going to continue this endless batting back and forth over the net. And frankly, it is actually, I think, inaccurate to say that any of the information that was discussed today is in any way materially different than what the witnesses said in their direct testimony, in response to cross-examination, and in response to my redirect. All of this was discussed during the main portion of the hearing, and intervener's counsel could have asked questions to his heart's content about any of this. It was all discussed, including the very point that Mr. Kannan just addressed, which is the history of and genesis and changes in the draft PCU policy, which was discussed at length by all the witnesses.
Mr. Hearing Officer, in the last hearing, they said that they were making changes relating to intubation. Now they're saying that they made other changes, so they're going to take everything that they're taking now, and that's a big change. And all I want to do is, since you have heard their answers to your questions, I'd like to allow Dr. Kurish to respond to their answers to your questions. In respect of the cases that are ICU level and the cases that can properly be taken now.
It would be unusual for me to allow that. I'll let you ask a few questions, but I'm not gonna let this turn into a long back and forth series of questions. If you have somewhere between 3 and 5 questions that you just wanted to have clarified by Dr. Kurish, that's fine with me.
Very good.
I'm also going to allow Attorney Tucci to do some cross following whatever questions you may have as well.
Who does based on the practice of the ICU at Sharon Hospital as it has been for the last several years, who do they take? What type of patients do they take that would also be suitable for the ICU at a bigger hospital like Danbury Hospital?
Well, I think our hospital takes a lot of critically ill patients and gives them good care. I mean, the hospital says that they can take care of these same people upstairs as they can take care of downstairs now in ICU, which I don't think would be the case at all. For example, respirator patients, as I pointed out in my testimony the other day, that most standard of care in PCUs is not to take intubated people on ventilators and not to take shocky patients, septic patients on vasopressors, and which we do right now in our ICU and take care of them very well. I think in the ICU we have nursing staff ratio of basically around 2 to 1, sometimes a little bit more. And that's what those kind of patients need. You have a person on a respirator in a room upstairs by themselves with a camera. It's not going to be suitable for taking care of those people properly. They need to be monitored continuously, and the vital signs need to be watched carefully. The rhythm strips need to be watched carefully by a nurse in a PCU, where open room, watch the respirator, watch the patient. They see exactly how they're doing. They try to pull out ICU, pull out their tube, whatever. They're right there to see the patient. Not a room down the hall that might be seen by a video camera, might not be seen by a video camera. And it's set up as totally unsafe where they propose it upstairs. I can go into details about other concerns I have about the unit upstairs, but the main thing is being able to have a nursing ratio with constant care for those particular patients, continuous constant care that they would not have upstairs with the ratios they're talking about upstairs. And that just applies, for instance, I just mentioned the respirator patients, but also apply to people coming with septic shock. Dr. Marshall thinks they can have the same care upstairs. You have to watch their urine output every hour, their vital signs continuously. PCUs generally don't take care of people that require vital signs or monitoring more than every 4 hours, sometimes transiently for every 2 hours. Other examples of that would be diabetics who suddenly get hyperglycemic and they can't control their blood sugars upstairs. They need to be in an ICU. They get blood sugars every hour. If they have nurses upstairs taking care of multiple patients, one nurse is going to require a total devotion of time to that one patient. It won't happen upstairs. You won't have enough staffing. What happens upstairs if a PCU nurse they sign up there, falls in sick? Let's say they have more than one sick patient upstairs. It's not going to work. Same thing would apply to a massive GI bleeders with NG tubes. You got to watch the blood coming out of the nose. Somebody on a monitor and watching a monitor in the back room is not the same as having a nurse sitting at the bedside or right across from the bed through a big whole wall of windows watching those patients. So the critical ill patients that we take care of now will not be getting adequate safe care upstairs. Somebody coming in with detoxification for DT is another example. Upstairs in another room, it's not the same as watching somebody having a grand mal seizure right across the room. They can catch it, get them IV Valium, whatever they need to control that patient's seizure activity. There's so many examples of the same kind of thing.
How about serious arrhythmia?
Same thing on the monitor. You have a nurse sitting at the nursing station watching the monitor. You can see a serious arrhythmia, tachycardia, heart goes too slow, goes too fast, ventricular tachycardia. The nurse there watching that monitor.
And what, do you think that it would be safer to have the model, the PCU model, staffing with nurses from the ICU and the med surge together?
Again, if let's say you have 2 or 3 sick patients, 4 sick patients that require Q1 hour monitoring. Upstairs, you can have 3 nurses, if you're lucky, maybe 4. How are they going to take care of those critically ill patients if there's more than 1? It's not going to happen. And the rooms that they propose are down the hallway. They put it in my original testimony. They're not going to, the person's not going to see those patients. The alarm goes off, they might be under the side of the floor. By the time they get there and hear the alarm with their alarm system, it might be too late for that particular patient. It's just not the same. They can say they can admit the same people there, but they won't get the same care. The ratios, 4, 5 up to 1, it's not going to work. Not going to work at all.
That's, I'll shut it down there.
Thank you, Attorney Knopf. Attorney Tucci, did you want to do any follow-up cross on Dr. Kurish related to any of the statements he just made?
Dr. Kurish,
Yes.
can you hear me?
Yes.
Couple of questions for you. So you heard within the last hour, Ms. McCullough testify under oath that with respect to 6 rooms on 2 North, they have already had the appropriate medical gases installed. Did you hear that testimony?
Yes.
You have any reason to doubt the veracity of what Ms. McCullough said?
On gases, no.
And the purpose of those gases is to allow appropriate equipment to be hooked up, including respirator equipment that will assist patients in breathing, correct?
That does not have a cardiac monitor, does not have.
I didn't
O2
ask you that,
saturation.
sir. Sir, you have to answer the question that I asked you. The reason those gases were installed in those rooms is to allow those gases to be available for use with ventilator equipment, correct?
Yes.
And ventilators are used to help patients who can't breathe on their own, correct?
I need more than a ventilator.
All right. And you talked about the issue of patients being down the hall. You are aware of the physical configuration of the
Yes.
hallways and rooms on 2 North, correct?
Correct.
And there is a physical location where the nurse's station is, right?
Remotely, yes, from the rooms, yes.
I'm asking you, sir, are you aware that there's a physical location where nurses are
far.
stationed, correct?
Yes.
And at the nurses station, there are computers and monitors that are there for the nurses to be able to view, correct?
No video monitors, just EKG strips. No
Okay.
oxygen levels,
And
no respiratory rate.
What,
I understand
asked that the witness be allowed to finish his question, his
I
answer.
apologize for interrupting. You go right ahead, Dr. Kurish. Say whatever you'd like.
They don't have a complete monitoring system there. They just have an EKG rhythm strip and heart rates.
Understand that. What I want to focus on is your understanding of the physical layout and configuration of 2 North.
Yes.
It is correct, is it not, that within the direct sight line of the nurse's station across from that hallway are patient rooms, correct?
Not the PCU rooms.
I asked you, sir, whether physically there were rooms directly across from the nurse's station.
Yes, there are.
Isn't that a fact?
That's a fact.
There's approximately 5 rooms within direct sight line of the nurse's station, correct?
Parts of the rooms are, yes.
Right. And
reasons.
Wait, excuse
excuse
me, Mr. Dr. Kurish was not allowed to finish his answer. Please allow him to finish his answer.
Yes, you can see into the rooms. You're not necessarily going to see the patient. You're not going to see their face. You're not going to see their legs. It depends upon the view of the station down the hall into that room. It depends upon whether the door is open or closed.
I'm talking about
It's incomplete.
Okay, I'm talking about the rooms directly across from the nurse's station.
Mhm.
A nurse can be seated at the nurse's station and without the need to look at a monitor or any other device or binoculars or whatever, see directly across the hallway into those rooms, correct?
You can see into the room, but not the patient.
Thank you very much.
Is that all you have, Attorney Tucci?
Yes, thank you.
Okay, thank you. I just wanted to make sure. So I think that concludes all the questioning at this time. I think we are prepared to do a run through of the late files that have come up today and last time as well. So we're going to do those, and then we're going to take maybe a 5 or 10 minute break. We'll do closing arguments, and then we'll wrap up for the day. So Attorney Tucci, Attorney Kanaga, are you prepared to discuss the late files right now?
Yes.
Okay.
Yes.
So the first one I have is actually for the intervener, Dr. Kurish. Attorney Knag, you said you would be submitting the written version of Dr. Kurish's opening statement from the first session.
Yes.
I would like to have that one filed by close of business on Friday.
Yes. That's 4:30.
Yes. And I think the rest of these will pertain to the applicant. So OHS has sought an updated utilization volume. And Mr. Clark, Ms. Faela, and Mr. Lazarus, feel free to jump in with any clarification. So I have these listed in, the way I would write them, but if these are listed incorrectly, just let me know. So I wrote down updated utilization volume from September through the present as number 1. Number 2 is average daily census by month and year for 2018 through the present. Number 3 is transfers made to other area service providers by month and by year for 2018 through the present. Number 4 is articles regarding the distinction between ICU and PCU, specifically high level versus low level units. And that's in reference to some comments that Dr. Marshall made about this being a high level PCU versus a low level PCU, the proposed unit. Number 5 is the MedPAC report from 2021. Number 6 is the most recent draft of the hospital's PCU admission policy. An earlier version of that was provided in the application. So we're just looking for the most recent version of that. And number 7.
Mr. Hearing Officer?
Yes.
Since much of our testimony was directed to the initial draft that was supplied, and now they're going to supply a revised draft, I would request that we be given a chance to comment on it once it's produced.
Attorney Tucci, do you have a response to that?
Yes, again, I think that's highly irregular, outside the scope of the normal CON process. We are through with the evidentiary portion of this process, and in essence, what what intervener is apparently asking to do, asking for is the ability to further comment on and or object to evidence, which I think is directly contrary to your ruling.
They should have provided us with the most recent admissions policy, so we could have commented on it in the direct testimony. We should be able to comment on whatever the current version is. Otherwise, our input has been unreasonably limited.
Well, I respectfully disagree. This is not a trial. The intervener is not a party. And what we are doing is satisfying our obligation to provide information in response to technical questions asked by OHS. That's what this hearing is. It's not a popularity contest and it's not a trial.
I think enough information has been gathered today to satisfy the agency in terms of how to make sense of this updated admissions policy. And also the additional articles and the last late file that I'm about to get to, I think will provide enough information such that we don't need a response from the intervener. So I'm going to deny that request, Attorney Knag, and move on to the last late file request, which is number 7, a side-by-side comparison of the types of acuity cases that can be handled by ICU and PCU as it specifically relates to Sharon Hospital and what their capabilities would be if this proposal was approved versus not approved. Steve, Ormond, Annie, did I miss anything?
No, everything on the list. Thank you.
And Steve, Ormond, Annie, does anything need to be clarified? Did I ask those or did I say those in the correct way?
No, I do not think so.
Okay. Attorney Tucci, do you understand? Do you have any questions about any of those requests? Or need any
Mr. Chuka.
clarification?
No, thank you. That was yeah, the list was clear. We don't have
Okay.
any questions about the requests.
So we're going to take a 10-minute break. You can discuss with your clients how long you think putting those together might take. And when we come back from that 10-minute break, we'll have closing arguments and we will also discuss the late file deadline as well.
Thank you.
So let's come back at 3:56. So you can start the recording. Thank you. Once again, this is docket number 22-32504-COM. It's Sharon Hospital's proposed consolidation of critical care services from an ICU into the PCU. We have completed almost everything for the hearing. I'm going to ask Attorney Tucci, did you have an opportunity to speak with your clients about a deadline for when you think you might be able to get us the late files?
Yes, thank you, Mr. Chuka. We would suggest March 17th.
I see no issue with that. So we could say by 4:30 on March 17th.
Yes, thank you.
Okay. So with the one caveat being that we're going to have the intervener submit Dr. Kirsch's written statement by 4:30 this coming Friday. That is February 24th at 4:30. So we're going to go into, oh, I'm
Excuse
sorry.
me, Mr. Chuka, I'm sorry to interrupt, but if I could just speak to that point briefly, and again, just to complete the record on timing.
Sure.
So as we've indicated sort of at the beginning of the hearing and throughout the course of the hearing, the applicant will be filing a motion addressed to the written pre-file of the intervener. And we would request until March 6th to file that motion with you. We will include in that any response as necessary to intervener late file number 1.
That works for me.
Thank you.
I think we'll have to evaluate once you file your motion, the amount of time that may be needed for the intervener to respond to that. So I'm not going to set a deadline on that right now. I do want to see the motion before I decide on a deadline for the intervener. So I'm going to just going to hold off on doing that for right now, but March 6th for the submission of your motion is fine.
Thank you.
So with that, I would like to first start with the closing argument from Attorney Knag.
Very well, thank you. OHS has already made a finding in its determination letter that a CON is needed here because the applicant wishes to terminate the ICU level of care. It made a determination that is not simply a consolidation of care, but a change in the level of care being offered. You should deny the CON application for 3 main reasons under the CON factors: the lack of identified financial benefit, the loss of access in needed ICU services in this rural hospital, far away from other hospitals, and the negative impact on quality of care. First of all, the financial benefit. The applicant has spoken about its plan to stem its losses, but nevertheless, in assessing the impact of this particular CON, the applicant assumed a further small financial loss in its projections as set forth in its completeness responses. It has not claimed that there would be any savings whatsoever from the resulting from the proposal based on the financial worksheets that it submitted. We believe that this, however, is likely very much understated. In its application in first and second completeness filings, the applicant projected volume will decline by 20 to 24 cases a year and 10% compared with 2021. But the thing that we'd like you to take a close look at is that after they issued this policy, which they say wasn't implemented, but which Dr. Kerr says was, after they implemented this policy, there was a decrease in ICU volume by approximately 40% on an annualized basis. That's what they say in their submission. And they said today that they didn't know exactly what the figures were thereafter, but they were more or less the same. So what we've seen is a 40% decrease in ICU volume. And this does not include this information about finances does not include the setting up of the PCU, such as the cost of monitors. The hospital's financial losses are also out of line with similarly situated hospitals in the state and must be evaluated as such. A look at another rural community Connecticut hospital with similar number of beds, Day Kimball, shows that it is now making money again without proposing any elimination of critical services such as maternity or the ICU. And per OHS data in the last published report in 2022, only 5 hospitals in Connecticut had operating losses for FY 2021. While the hospital's council has chosen to call some of the claims that we make a conspiracy theory, we know that the hospital itself was told by Stroudwater Associates to move volume to applicants' other hospitals with a view toward the overall system's bottom line, and that it should evaluate Sharon Hospital's bottom line to include the benefits to the system from items taken from the Sharon Hospital income statement. Nuvance's actions are aligned with this advice. It is interesting to further note that a decision has been made to discontinue the use of the teleintensivists at the ICU and replace them with guidance from doctors at other Nuvance hospitals who the hospital states would likely be involved in arranging for transfers. Again, the facts show that Nuvance's actions have resulted in moving patients out of Sharon to other Nuvance's hospital. This is data. It's not a conspiracy theory. Now let's talk about the loss of access. So there's no financial savings as a result of this. Let's talk about the loss of access. The decrease in volume is tied to a loss of access to ICU services. Although the applicant claims the revised admission policy was never formally adopted, Dr. Curry says it was adopted. And he gave an example of a patient with a drug overdoses who needed emergent intubation in the emergency room. The hospital insisted that the patient be transferred, but an ICU bed couldn't be located in another hospital, and the patient was admitted to Sharon's ICU and did well. The applicant seeks to justify closure by the claim of low utilization of the 9-bed ICU. And one key reason for the low utilization is that the unit has been limited to 4 patients on many days due to nurse unavailability. And that was a problem that was exacerbated by the applicant when this hospital CEO told the ICU nurses that the ICU was closing, prompting a group of ICU nurses to quit. And ever since then, there's been chronic understaffing problems in the ICU. This has never been a problem previously because Sharon is a wonderful place to work and it has a strong record of recruiting and retaining staff. Additionally, we mentioned that one ICU room was used for storage, not patient care. We know that 92% of the hospitals in the Northeast, the size of Sharon, have ICUs. It's not true that in general that the hospitals in the Northeast have been closing the ICUs. In recent months, and also at the start of COVID, there has been a shortage of ICU and med-surg beds. On certain days, Sharon, Danbury, and Vassar all were full to capacity. Under these circumstances, it makes no sense to take 8 or 9 beds out of service in the state by closing the ICU. And we would point out that Dr. Marshall admitted that by approving this application, 9 physical beds will be taken out of service. And the applicant hasn't revealed what it plans to do with this vacant space that would be available at critical periods such as we've just experienced. In addition, Sharon Hospital is in a rural and remote part of the state, 37 minutes from the closest ICU in optimal travel conditions. And today it's going to snow, and I'm very apprehensive about how long it will take me to get home from this area. As Nuvance predicts, its proposal would decrease the ICU patients by 20 to 24 cases annually, and now they say there'd be none, but we say there would be many more. And that would mean that more families would have to travel unnecessarily to visit with their critically ill family. And also, we know that the patients would be subjected to additional costs. For example, if a patient needed to be moved, the insurance might not cover it, especially if it was an air transport. And also the transferee hospital might not participate in the same payer contracts as the Sharon Hospital. Furthermore, in representing hospitals, one of the first things you do is you go to the community leaders and show that the community leaders feel there's a need, and you append to the CON statements of support from the community leaders. Here, nothing could be further from that circumstance. And in particular, we've submitted many letters from state legislators, from the town leaders, but I would point you to the letter just received on dated February 17th from Senators Blumenthal and Murphy and Representative Hayes. In particular, this letter urges rejection of this application, and it states that the Northwest Connecticut community strongly supports a viable Sharon Hospital that provides a comprehensive range of services. And this assessment by the community leaders from Senator Blumenthal and Senator Murphy on down show that there's a strong need to continue access to the hospital's core services, including the ICU. It's not a pressure tactic, as Mr. Tucci said. It's an assessment by the community leaders as to what the community need is. And just as it would be taken into account if the hospital was putting it in support of its application, it certainly should be strongly taken into account when the leaders are all clamoring for this application to be denied. Let's talk about the key issue, and another key issue, and that is loss of quality. There is no doubt that the termination of an ICU and creation of a PCU will result in a loss of capability and quality. The ICU nurses are trained to deal with ICU cases. They must be able to identify life-threatening arrhythmias, septic shock and respiratory failure. They manage respiratory patients with sedating medications, detoxify patients with overdoses that can seize or become psychotic, support massive GI bleeders with low blood pressures, and manage complicated post-op patients. The med-surg nurses don't have this training now. The applicant states that the ICU nurses will mentor the med-surg nurses who will receive additional training online. But it is clear that having nurses who have spent decades doing this in a highly specialized ICU care is superior to trying to train the med-surg nurses to take on these duties on a part-time basis. Furthermore, we know that the mere announcement of the proposed conversion from ICU to PCU has led some ICU nurses to quit, and that some med-surg nurses have stated that they will leave the ICU if, in fact, it is closed, and they would do so for fear of losing their licenses due to what they perceive as unsafe practices. So the shortage of critical care nurses that we now have may get even worse if this application is approved. And there will be a loss of the trained ICU level nurses. If the CON is denied, there will be the opportunity to get these nurses back who left in anticipation of an ICU closure. Because the ICU is a higher level of care, the ratio of patients to nurses is higher in the PCU than the ICU. According to the application, the proposed ratio in the PCU is 4.5 to 1, whereas in the ICU, the ratio is supposed to be 2 to 1. The national standard for PCUs is 3 or 4 patients to 1 nurse, but they're proposing a worse ratio. In addition, the proposed PCU rooms are patient rooms which are not designed for critical care and are too small. There are only a small number of patient rooms that are partially in the line of sight of nurses at the med-surg nurses stations. But the med-surg nurses may or may not be sitting at the station, and the patient and the fact that part of the patient room may be visible is a lot different from the line of sight that exists in the ICU, where the rooms, where there's glass on one side of the room, so that the entire patient, all the patients are in the direct line of sight of the nurses. Much information was presented as to the cardiac monitoring with alarms, but alarms are different from direct observation. Furthermore, the eight actual cardiac monitors, the portable cardiac monitors, only monitor heart rate. They do not include respirator rate or oxygen saturation. Again, today, they said only 2 rooms are proposed to have hardwired ICU quality monitors, whereas all the ICU rooms have hardwired monitors now. And while layman watching monitors designed to see whether the patient is suffering a fall may be sufficient for a medical surgical patient, this level of monitoring is not equivalent to continuous visual monitoring by a specialized nurse, which takes place in the ICU. We all know that I'm sure everyone has been in the hospital where alarms have gone off and no nurse has done anything. It's a lot different from having a nurse in direct line of sight. So if this application is approved, there's also going to be a loss of average competence in the nurses. The average training and experience will decline. The staffing ratio, as I said, will decline, and patients will be in rooms where there is not the open architecture of the ICU. Therefore, with all these factors, the hospital will not be able to provide the continuous visual monitoring that they are able to provide in the ICU. Now, they say that everything will be the same, or they'll take the same patients. But they can't do that safely. According to the 2021 policy, the PCU would not accept patients with respiratory problems needing intubation or ventilators or BiPAP support who are not hemodynamically stable. These patients are currently being handled in the ICU, and Dr. Marshall says now they will be handled in the PCU. But Dr. Courish states that such care is not provided in New Milford or Vassar and would imperil the patients if provided. And Dr. Marshall has admitted that the proposed standards for the new PCU would take higher acuity patients that are not admitted in New Milford Hospital. And he also admits that respirator management is one of the most difficult duties of an ICU requires. Without skilled, meticulous attention to detail, the patient could rupture a lung, suffer brain damage, and die. Other groups being handled now in the ICU, but not so suitable for the PCU, include hemodynamically unstable patients requiring prolonged close monitoring, clinical conditions requiring ICU nursing care, and prolonged hourly monitoring. Examples would be GI bleeding, not hemodynamically stable, patients with sepsis, with UTI, upper urinary tract infection, or pneumonia who need prolonged vasopressors. Vasopressors are medicines designed to keep the blood pressure up in the normal range until the infection is brought under control. And also arrhythmias that need continuous monitoring by a nurse. The big difference is the nurses and the monitoring. You have fewer nurses, you don't have line of sight, you can't monitor them in the way that that they are monitored in the PCU. And therefore, these higher acuity cases that are currently taken cannot safely, they can change the policy and say they'll take everyone, but they cannot safely be taken. Furthermore, in Sharon, we have the problem that it's remote, and there are times when patients can't be transferred due to weather or unavailability of ICU beds. They may need to take cases that normally they wouldn't want to take. And they need to be prepared for these cases in the best way possible. And closing down the ICU level of care, which is what they're asking to do. And instead substituting the PCU level of care would mean that dealing with these patients who can't be transferred immediately would be more difficult or impossible, imperiling the lives of these people. The ultimate result of approval of this proposal is that persons who are very sick or have serious injuries but could be treated in the ICU will need to be transferred, even though they say that they won't, which could imperil their health. They will not be treated in a five-star hospital, which Sharon is, and they will be subject to substantial incremental costs. They will also be far away from their loved ones. And those patients who are not transferred will be imperiled by the lower quality of the PCU compared with the ICU, in view of the factors I've just reviewed. Someone intubated or on vasopressors and hemodynamically unstable would, as the hospital had indicated in its drafted admissions policy, be inappropriate for the PCU and would be imperiled if they were admitted as now is being suggested. Now, what else do we know besides the fact that the community opposes this and the community leaders opposes this? We know that the medical staff of Sharon Hospital voted against the plan 25-1. This shows that the doctors who deal with these patients who are treated in the ICU, the doctors who every day have to tend to their patients, agree that this is the wrong thing to do. ED doctors, surgeons, and community internists were all against it. The ED doctors want to admit their patients from ED quality quickly without spending time trying to find a place to transfer the patient. It could take 3 or 4 hours from the time a decision is made to transfer a patient until the ambulance leaves with the patient. Surgeons want the ICU for patients with complicated comorbidities and post-op problems. And internists need a place nearby to handle their most seriously ill patients. Closing services such as the ICU would gut the hospital. And rather than doing that, the hospital should join with the community in working with the state officials, such as Maria Horn and the various committee chairmen of different state legislative committees who are interested in finding a way to obtain increased reimbursement from the state for the services being rendered by rural hospitals and in particular Sharon. And also they should work with the community to find contributions that would help to subsidize the services that are being rendered. And also taking steps to restore volumes, which they haven't taken, that is to replace, in particular, to replace the various doctors that have left. And I would point out that, and as Maria Horn did in her letter, that New Vance's Putnam Hospital closed maternity and recently reopened it based on the efforts of the state to increase the willingness of the state to increase reimbursement and the willingness of the community to increase charitable contributions. And rather than leave this community in the lurch, as has been suggested by all of its leaders, we ask that the hospital work with us to find a palatable solution that leaves the hospital's core services intact and allows the development of a plan that would address the financial concerns that they have.
Thank you, Attorney Knock. Attorney Tucci, are you prepared to deliver your closing argument?
Yes, thank you, Mr. Chuka. The first thing I'd like to do is to thank you, Mr. Chuka, and all of OH as staff for all the hard work that you put into this application and the public hearing to ensure that the process ran as smoothly as possible and that all of the facts and data came out. We appreciate that very much. I've been involved in certificate of need proceedings for longer than I care to admit on the public record. I have to say, I've never quite heard anything like or experienced anything like what I've experienced in these last two hearings involving Sharon Hospital. Typically, when there are interveners, interveners bring to the table facts, data, expertise, specific information relating to the merits of the CON application that are of assistance to OHS in evaluating whether or not the CON criteria are met. What we have experienced in these last couple of sessions is intervener participation that consists of speculation, fear, innuendo, accusations against the good faith of the hospital, not facts, not data, not reliable information. In fact, in the face of data, in the face of facts, in the face of reliable information, we get, as you just heard from Interveners Council, we don't care. We just don't agree with that. It isn't true. We don't accept that. I respectfully suggest that none of that has been of any use or any help to OHS in the work that you need to do to determine whether or not this CON application is in the best interest of the citizens of the state of Connecticut. More fundamentally, what you've heard is not only information that isn't helpful, but actually advances theories and themes that frankly appear to be without any rational basis whatsoever. And I don't mean this, I don't know any other way to say this, but in many respects, untethered to reality. The notion that Sharon Hospital's operational difficulties are going to be solved and have not been solved because we haven't worked hard enough to get contributions. I will state now for the record, if there's anyone out there who's willing to write a check for $20 million and contribute it to Sharon Hospital, we will gladly accept it. If the notion that the legislature of the state of Connecticut is going to write a $20 million check to cover operating losses at Sharon Hospital, I can tell you that the latest headline out of the executive branch is that there will be further cuts to hospitals and hospital operations. Not some vague hope that there will be a financial bailout that comes to the aid of rural hospitals like Sharon that are struggling. And quite frankly, even if there was any realistic possibility of that ever happening, it absolutely is not good healthcare policy and has nothing whatever to do with the CON factors that you're required to apply to suggest that the way to solve our problems about how to make rural hospitals like Sharon most effective and most financially self-sustaining and to create the care that is in demand and is appropriate for their service area is by continually bailing them out. The definition of insanity is to continuing to do the same thing over and over again when it produces the same negative result. So let's talk about when we started this process. I think one of my introductory comments to you, Mr. Chuka, was that this is a relatively straightforward request to relocate the critical care services that the hospital currently offers to a new physical space on the second floor of the hospital to be called a progressive care unit. I think we've actually proved that through all the facts and the data and the testimony that you've heard. So I think my comment was largely accurate, but it's incomplete because really what this application represents is, and coupled with the prior application that was submitted, a referendum on the future of Sharon Hospital. And what has been proposed here is a transformation plan that not only satisfies all of the factors that you've identified as the critical factors for CON approval, but will actually ensure that this hospital has a viable future in the community for the next 10, 15, 20, 25 years. When you opened the hearing, you talked about the key critical CON factors that need to be evaluated and that would be tested here in the technical portion of the public hearing. And they're well known: need, quality, access, cost effectiveness. So what have we proved? I'm not gonna go through and catalog all the evidence because it would take too long to do it. But just briefly, what have we proved with respect to each of those factors? With respect to the need for critical care services in the Sharon service area, we've absolutely demonstrated that that need will not only continue to be met, but will be met in a higher quality, increased access manner through relocation of our critical care services to the second floor with a PCU unit. The consolidation of this critical care function and creation of a mixed acuity unit is not only more cost effective, because as you heard from the testimony today, we're now paying nurses who sometimes are sitting in a unit where there are no patients to serve, is not only more cost effective, but will actually increase access of critical care services and the quality level of those services, which is already very high. So how will that happen? Well, you've heard it explained in great detail. When you're able to pool your resources so that all of the inpatients that are being cared for in the hospital are in a single location, all of the nurses, all of the attendant healthcare professionals, all of the service staff will all be in the same location. That unit can be flexed up or down, meaning that if there's a higher number of patients who require critical care services, they will be able to be accommodated because there's a 28-bed unit. With respect to the staffing ratio, you've heard a lot of fear and speculation about that. Again, fear and speculation about whether medical surgical nurses are going to be adequately trained is just that, fear and speculation. Of course, they're going to be adequately trained. What is the converse of what the intervener is suggesting? Apparently, the intervener is suggesting that what we are proposing is to establish a new physical space on the second floor of this hospital that is going to be less safe for patients, that's going to expose us to more risk and potentially create harm to patients. Why in the world would we ever do such a thing? The facts completely belie that fear, that speculation, that innuendo. You've heard from Ms. McCullough, you heard from Dr. Marshall. The physical space on 2 North meets the quality level and standard of care to deliver critical care services. You've heard described in excruciating detail every type of monitor, alarm, system, and the increased level of staff that will be in place on 2 North so that there are more eyes on patients, more interaction with patients who require critical care services, not less, but more. The increase in access is apparent on its face. Why has there been, the intervener would ask you to believe that in some form or fashion, there is a critical shortage of ICU beds, not only at Sharon Hospital, but throughout the system. The facts and the data belie that. We're limping along here with a physical ICU that is basically half empty every day that it's open. And for 50% of those 4 patients who are in the unit, in most other hospitals, they would be in a medical surgical unit because they don't even meet the necessary standard to be in an ICU of the nature of Danbury Hospital. Let's talk about the financial picture here that has been addressed briefly by Mr. Knag in his comments and also through the testimony of Mr. Jermak. The theme and theory that's being advanced to you, which again, I would respectfully suggest has no basis in reality, is that the grand plan here is for Sharon Hospital to turn away patients that it could otherwise profitably serve, and to intentionally take business away from Sharon Hospital in order to get this CON approved. How could that possibly make any sense whatsoever? What's been going on here for the last several years is every attempt to find a way to keep this hospital financially viable. And it makes no sense to say that patients are in any way being turned away when they could be cared for here. You heard the evidence. The evidence is overwhelming. The reason why Sharon Hospital transfers patients is because they need to be transferred for their own safety, because they require care that they can't get here. What we're talking about when we have a system like Nuvance is actually quality and access and better care results when those patients are able to be transferred to a hospital that's part of the Nuvance system, because the clinician at Vassar or the clinician at Danbury who takes a patient at Sharon Hospital is actually able to look in real time at that patient's medical record to understand what the history of that patient was, what care they need, to provide the specialized level of care that patient needs at Danbury or at Vassar or at some other hospital of the patient's own choosing, which is another myth that's propagated by the interveners here, that somehow Sharon Hospital has the power to dictate where a patient goes. That's absolutely false. The evidence doesn't support that. And so why is this the right model for a hospital like Sharon? Because it makes perfect sense to have Sharon Hospital be the lifeline for patients who need critical care, the lifeline for patients who need emergency care. They get that life-saving care at Sharon Hospital. If they need equipment, if they need specialists that isn't available at Sharon Hospital, they should go to other hospitals where they can get that care. If it so happens that the patient elects to get that care at another Nuvance hospital, so much the better, because the quality of their care will be enhanced because the clinicians are part of the same system. They look at the same medical record, they talk to each other. And you heard testimony from Ms. McCullough and other witnesses about how when those patients come back to Sharon Hospital, they're able to get that continuity of care that they need at Sharon without any interruption or any need to look at records that are generated by another hospital. Much was made of the support of public officials, politicians, and so forth, who oftentimes are wont to weigh in on these sorts of things. I understand that, but as long as we're talking about public comment, let me just briefly refer back to the witness after witness who testified about why the PCU model, who weighed in during the public comment session, who talked about why the PCU model made clinical sense, made economic sense, was in the best interest of patient care. You heard from witness after witness affiliated with and connected with Sharon Hospital, emergency department physicians, other medical doctors who are on staff, people who are in charge of the EMS part of the emergency transport program, all coming out and speaking in favor of this because they know it's the right thing to do in order for Sharon to be able to deliver cost-effective and quality critical care services going forward. In terms of the financial aspects of this, you heard very detailed and very clear testimony from Dr. Murphy about how the beauty of this proposal to really save Sharon Hospital and make it a vital resource for its community going forward is that the sum of the transformation plan is greater than its parts. And when you put it all together, that's what's going to allow the hospital to have any realistic hope of remaining financially viable as it goes forward to try to provide the care that patients need. What have you heard in response from the intervener besides speculation, innuendo, and fear? Well, what you heard from Mr. Jermack was essentially a made-up calculation that somehow there's a magic $13 million worth of revenue out there that if the hospital didn't transfer patients, somehow Sharon Hospital would be able to garner that revenue. Well, I don't think anything more needs to be said about that so-called calculation, because it's clear on its face that it has absolutely no merit or basis on its own. The other myth that I think has been exploded here today is the notion that somehow if this application is approved, something is going to be taken away. There's a termination, there's a closure, there's a deprivation of some service, product, or medical care that the community would otherwise need. That myth has been completely exploded over and over again by every witness who you heard testify under oath. Let me state this as clearly as it can be stated. The critical care services that are currently offered at Sharon Hospital today will be of the same level and quality and intensity when the PCU is up and running if you approve this application. There's no ifs, ands, or buts about that. It's just a fact. When I thought about how to conclude this, I think I do need to ask you to just briefly consider what will happen if OHS decides that this application shouldn't be granted. Well, essentially, what you will be doing is dooming Sharon Hospital to be stuck in the past. We'll continue to limp along with an ICU unit on the first floor that is staffed by 2 nurses who may or may not have anything to do. And when patients are there and the nurses are not available, we won't be able to deliver the care. The unit is outdated. It's going to require a significant capital investment if it has to continue in its current form. And for what purpose? All that will be happening is that we'll continue to maintain the status quo, which is a half-empty unit where we're struggling to staff it appropriately. And when we do staff it, there's actually less demand than is otherwise needed to keep that unit financially viable. You know, I think there's really nothing more to be said about why approving this application makes sense, other than the words that Dr. Murphy used to help describe why this is so essential for the future of Sharon Hospital. The $20 million deficit that's been talked about here, that's really not the problem. That's a symptom of the problem. If the hospital is able to re-engineer itself so that it's able to offer care that is financially self-sustaining, care that the community needs and wants locally, that will go a long way toward ensuring the future of Sharon Hospital. The single biggest threat, as Dr. Murphy said, to Sharon Hospital is the status quo. We respectfully ask you, change the status quo, grant this application, allow Sharon Hospital to continue to provide high quality, needed critical care services in a new PC unit at the hospital. Thank you.
Thank you, Attorney Tucci. That concludes the hearing. Thank you to everyone who has attended both last week and today. Thank you especially to counsel and their witnesses. Just a reminder that written public comment can be submitted up to 7 days from today. That is March 1st, 2023. After that, it will not be included as part of the hearing record. I believe that is everything. So this hearing is hereby adjourned. The record will remain open until closed by OHS following the submission of the late files that were discussed earlier in the proceeding. Thank you again, and take care of yourself.
Thank you.